Hello, everybody. It is a great pleasure to be here and present for you during this conference. My name is Gregor Kasprian, and I am a neuroradiologist with a special focus on pediatric neuroradiology and especially on fetal neuroradiology. I know that your country is currently going through very, very serious times. And I hope that with my lecture, I can bring some more different views and aspects into your lives, which probably stimulate you to go forward and see also the positive aspects of life for the future. My role here is to speak a little bit about prenatal epilepsy imaging, a term I just brought into the life. I think that is not a discipline which is happening right now, but I think this discipline will evolve for the future and will be a very interesting way to go into the future, at least I think. This is the place where I'm walking. This is the AKH in Vienna. It's a 2,000-bed hospital. It's the largest medical university in our country of Austria. And we are seeing many, many different cases. Children, the Children's Hospital is right here. And we have also a cancer center, St. Anna, which is about here. And we are seeing epilepsy cases, we're seeing tumor cases, and we are very much specialized in the field of prenatal imaging, prenatal MRI imaging. So when we think about pediatric radiology and pediatric neuroradiology, there is one thing I think is crucial to be aware of, and that is that the only constant in our life is change. We're permanently undergoing change, even if it feels quite constant and quite stable. We are undergoing permanent changes. Always our body, our structure is always changing, and that is particularly true for children. Why I am saying this is because medicine has changed quite a bit. I give you an example here of a 4-year-old with the first seizure. So first seizure, child goes to hospital, is seen by neurologist, is also referred to MRI. So after some time, an MRI is done, and these are the images. And if you're looking very closely and you're trained in epilepsy imaging, you will be aware that there is a region in the fetal brain right here which looks somewhat abnormal. So this is a schizencephalic cleft, which is probably the reason for that seizure. And in this case, the boy was treated and so far is doing well without surgery. Why I'm showing this sort of usual case to you is because we knew this boy already long time before, at 23 gestational weeks of life before birth in utero. And look how this polymicrogyria schizencephaly is looking at prenatal stages. You see that it seems that somebody bit some piece of the brain out here in this baby, in this fetus, and you see this irregularity, and this evolved into the schizencephalic cleft we're seeing postnatal. So we are seeing brain malformations currently at time points we have never seen them before, and that is due to the huge advances in ultrasound and imaging. This also means that we are for the first time able to assess a process we call epileptogenesis throughout its genesis. It's basically its appearance. So what is epileptogenesis? Epileptogenesis is a process where genetic or acquired etiologies or insults, ischemia, lead to functional and structural reorganizations of a certain network, and lead by that to changes in the brain. And these changes themselves cause epilepsy, cause the generation and progression of spontaneous seizures. So it is a process of basically making the brain epileptogenic, causing the brain to fire rapidly spontaneous electric activities, and by that causing seizures. And that is a very complex pathophysiological mechanism. I'm not going to take you through all these kind of receptor changes and whatever you see here, but just simply said, in our brain, there is a balance between excitation and inhibition. And if excitation is basically too much, we will have seizures. Is inhibition too few, we will also have seizures. And this balance is a very delicate balance and can be influenced by structural alterations. In terms of inhibition of the brain, I would like to mention the GABA receptor, which is a very important receptor causing inhibition in our brain. Now, the question is there something like an epileptic seizure or epileptogenesis in utero? Well, there are only hardly any epileptic seizures described prenatally. So far, we only have a documentation of seizures in about 50 cases all over the world by ultrasound and by MRI. This is one of the cases we saw where you could see these repetitive leg movements in this baby. So we believe that this was a seizure, and the cause of the seizure was an alpha dystroglycanopathy, so a Walker-Warburg syndrome in this case. So the epileptogenesis prenatally differs from what we see postnatally. The special thing here is that GABA, which is usually an inhibitory neurotransmitter, is excitatory during prenatal stages of development, and then will become an inhibitory transmitter. So the function of certain ion channels and certain transmitters prenatally is different than from postnatal. So where are these inhibitory neurons coming from? And here I would like you to introduce a structure which you probably are not too much familiar with it postnatal neuroimaging, but at prenatal neuroimaging you have to know it because you can see it. And that is the ganglionic eminence. This ganglionic eminence is the origin of these inhibitory interneurons, and they are coming from this region and they are migrating tangentially to the surface of the brain. This ganglionic eminence is a structure here located medially to the lateral ventricles and is a cell-rich zone, which is then continuously growing during early stages of pregnancy, but then, and that is the special thing, also decreasing in size. So again, here, this is a post-mortem fetal MRI at 17 gestational weeks, where you see the ganglionic eminence very nicely right here. And this would be the zone where those neurons, inhibitory neurons, are born and migrate towards the cortex. And that is how it looks like in fetal MRI prenatally. You see this dark zone here. This is a zone with a lot of cells where those inhibitory neurons are born and will migrate to the cortex. And here I'd like to state the following description of Charles Scott Sherrington, who is a Nobel Prize winner, describing the phenomenon of pruning and synaptic transmission. And what Sherrington said is that it is equally important for our brain when it's growing to basically get rid of stuff as it is to grow. So we need to get rid of structures in order to mature appropriately. And The central nervous system is not a painting, it is a sculpture where basically the form, the shape forms after removing stuff. And that is certainly true for this ganglionic eminence here, a histological image and the post-mortem MRI image. Here you see the in vivo super resolution 3D reconstruction with a in vivo reconstruction of this structure by my colleague Marlene Stümpflen right here. So reconstructing the three-dimensional shape of the ganglionic eminence allowed us also to measure the volume of this structure, where you can see that it is continuously decreasing from about 20 gestational weeks onwards until 30 gestational weeks. So it's basically decreasing in size. And also, again, here you can see that at 19 plus 0, it's quite a remarkable structure, and then it decreases and continuously disappears in size. It's even more impressive if you compare and form a ratio between the volume of the ganglionic eminence and the cortex, where you see the cortex is continuously expanding and growing, whereas the ganglionic eminence is decreasing in size at the same time. And so you see this basically a pattern of this inverse relationship between cortical growth and decrease of ganglionic eminence size. Why am I telling you all this? Because recently a series of disorders has been described to involve the ganglionic eminence. These are tubulinopathies, mTORopathies, alpha-dystroglycanopathies, and many other disorders. We are currently seeing more and more conditions which are associated with a too large or too small ganglionic eminence. And this is just an example image in utero at 22 plus 2 gestational weeks, where you see a huge ganglionic eminence with cysts here. This is a 3D reconstruction. And this was indeed a mitochondrial disorder. So also mitochondrial disorders can be, metabolic disorders can cause migrational alterations here in the ganglionic eminence. And this is a age-matched control for comparison. And here the 3D comparison between the control and our case, where you can see the enlargement of this structure compared to the normal control. And if we measure the size of that, you can see it's clearly above every other normal case. So it's an enlargement of this, severe enlargement of this structure. Another case imaged at 26 weeks, usually just take note at 26 weeks, you will not find much of a ganglionic eminence right here. It's very, very small. But sometimes you can see a case like this where the ganglionic eminence is too thick and still present at the time point where it should have disappeared at 29 gestational weeks. We can, in the meanwhile, also perform tractography prenatally and also on gray matter structures, which allows us to see the intrinsic geometry of the structure. And you can see that there are changes to this structure in our pathological case right here compared to the normal one with the normal microstructure seen on DTI right here. So what is this? What pathology is this? We did not know, but now we had the possibility to follow up this structure and measure it, and we could see also it was larger than the normal reference values. And postnatally, look at these images. At the age of 2 years, this baby was right after birth having severe epilepsy with severe seizures, catastrophic epilepsy, therapy resistant. And if you look closely to this region right here, next to the caudate nuclei, you see there is a hyperintense region, and I believe these are the remnants of the ganglionic eminence, and they are still basically causing the brain to generate seizures. And this was backed by a genetic examination where we found a GABA receptor variant. So the GABRB2 receptor was mutated, and this nicely fit together. So the origin of the interneurons was abnormal, the ganglionic eminence. There was a mutation in the GABA receptor, and altogether led to a overweight of excitation versus inhibition in this brain and caused this catastrophic epilepsy. A nice case to demonstrate that the origins of these disorders are often prenatally present and can be visualized by radiology. Sometimes these changes are very subtle. This is just a very subtle alteration right here. We did 3D reconstruction where we found this kind of band underneath the cortex, and that's how it looked like postnatally. You could see that there is a band of gray matter in the white matter. So this is a localized band heterotopia. Also, a brain malformation. Interestingly, in this case, there was no epilepsy. So not all of these brain malformations immediately cause therapy-resistant epilepsy. And that was also the case for these three guys here. You see 3 different cases imaged at 4 years, 2 years, and 11 weeks, all with the same problem, with a schizencephalic cleft with the parietal lobe right here. All 3 cases were imaged also prenatally, and we're looking like this at 23, 26, and 21 gestational weeks in utero. In all cases, you could see that there was a defect to the brain, which was most likely ischemic, because there was a second commonality to all these 3 cases. They were all twins. They had a co-twin which demised, and these were cases of a twin-twin transfusion syndrome. And in this setting, we have a high likelihood of ischemic events, particularly in the acceptor fetus. The donor died here in those cases, and we had these ischemic events, and they resulted in a localized schizencephalic cleft with polymicrogyria after birth. And there was a third phenomenon here. These cases were seizure-free. So it was amazing that we have a brain malformation where we know this is often causing epilepsy, but all of those cases were followed, and so far they are seizure-free. What we're also doing is to look at function prenatally, and you can see here one of those cases did not have a lot of arm movement, so we thought that there is a hemiparesis, and here you could see the normal reference data. We are working with a group in Japan where we try to quantify fetal motion a little bit. And this is not unsurprising because the lesion was right to the central region of the brain here at 21 weeks. So we thought there will be hemiparesis, but we were very surprised because this is the girl postnatally, and here you see her twin girl, and you could see that this girl is moving really, really nicely, and you don't see any clear hemiparesis. Maybe she's not using her hand a lot, but generally she is doing quite well. So we are closely following her and closely seeing if epilepsy develops, but so far, as said, she's doing fine. So if we go back and think about which lesions are epileptogenic in an infant brain, we have some lesions which are about 100% epileptogenic. And these are the lysencephalies, hemimegalencephalies. A lot of mTOR pathway problems, tuberous sclerosis, are almost 100% epileptogenic. But there is a series of problems where these lesions can or could cause epilepsy, but are not always causing epilepsy. And schizencephaly is one of the most prominent amongst them. So this is a very interesting group, and we need to understand more, and we need to understand which factors contribute to the development of epilepsy in those cases, and maybe we have some tools to prevent the genesis of epileptic seizures. But in order to do so, we need to understand more about fetal brain function, which is per se spontaneous. You can see initially these cells are firing quite independent from each other, but then they are firing together. So the synchronicity is basically changing throughout pregnancy. And that's exactly what we could see through by functional fetal MRI. So what we do here is a bold sequence in utero, in vivo, and we are basically measuring the connectivity between certain brain regions by measuring their synchronicity in time changes in their brain signals on MRI. Of course, this requires a lot of post-processing and motion correction, but I think we are on a good way to handle these problems. And here you can see that at around 27, 28 weeks, there is a tremendous increase in the connectivity towards the calcarine, the primary visual cortex. So this is the time point where we believe that there is an ingrowth of thalamocortical connections, of visual pathway connections to the primary visual cortex. And interestingly also, the synchronicity between two hemispheres is also changing over gestational weeks. So we see more and more non-homologous connections popping up at later stages of pregnancy. So also the interhemispheric connections are developing. I'm just pointing this out because I'm strongly believing that epilepsy is a network disorder, and understanding these networks through neuroimaging and through fMRI is certainly a very valuable way to approach the problem. And I think also epilepsy imaging nowadays starts not only after birth, when we see the seizures. Epilepsy imaging starts prenatally because we're detecting more and more of these brain pathologies at prenatal stages of development, and there we need to understand how they are going to evolve and what they mean for the affected children. And I think neuroradiologists and pediatric radiologists are required to contribute their expertise they have, certainly from postnatal imaging, also in this field of modern neuroimaging. And I think if this all works in the future, we will be able to use therapies very early to influence the process of epileptogenesis and maybe prevent the generation of therapy-resistant seizures by early treatment interventions. With that, I'm happy to have contributed to this conference, and maybe I will meet you again once in person. I would be delighted. This is my group in Vienna, so it is an interdisciplinary endeavor between pediatrics, obstetrics, but also computational imaging research. But I don't think that you need all of that to do fetal MRI. If you're interested in the technique of fetal MR, we are going to offer a comprehensive course on fetal MR imaging starting this autumn, provided by our university, and with the possibility to visit Vienna for 2 weeks and also have a hands-on training here with our technicians and radiographers who are really into that field a lot. So thank you for your attention, and it was a pleasure.